Welcome to Balls Deep, a humorous yet informative medical show with a mission of optimizing your performance in the bedroom, the bathroom, and the boardroom. I'm your host, Dr. Joe Pazona, a board-certified urologist and CEO of Pazona MD. We hope you enjoy. Now, let's jump right in. Hey Stream Team, Dr. Joe Pazona, board-certified urologist and CEO of Pazona MD, and welcome to another episode of Balls Deep. Again today, we have a guest. Our last episode was so well received, we thought we would bring Brooke back again. So Miss Brooke Faught, welcome and thanks for coming.
Thank you for having me again.
Now, just to be clear, you know, if y'all haven't noticed, we batch these episodes, right? I mean, I did not change my clothes. Like, you know that it's the same exact day. But as we see, Brooke actually brought an extra shirt I don't know. I mean,
this ain't my first rodeo.
Yeah, you've done this before. Yeah.
Times are clearly tough, though, here with Joe Pazona, and he only has one shirt. I'm sorry.
Yeah, exactly. the guy black polo and the woman who's got the 10 shirts for today.
Of course. A lady doesn't show up to a podcast with the same outfit. Come on.
Absolutely not. And now I'm worried the next time Kat comes back, she's going to be doing her wardrobe changes, which means we'll be here for about 5 hours.
Yeah, probably. Yeah. Sorry about that.
Yeah, thanks, Brooke. So I thought we'd continue our menopause discussion. Hopefully you've watched our previous episode, and if not, I think it'd be a great starting point before jumping into this week's episode. You know, Brooke, with that, we hope to answer the question or the concern that, living with menopause is not okay, right? And the symptoms related to it, that being stoic, suffering in silence, you're just hurting yourself and you might be leading to an early death.
Yeah. There's a lot, as I mentioned, a lot of collateral impact of untreated menopause. And while not all women experience a full-fledged series of symptoms or need or require treatment or intervention, those that are feeling the symptoms of menopause need to be aware that there are people that are knowledgeable that can treat this condition, and there are a slew of treatment options, some hormonal, some non-hormonal, some local, some systemic. You just have to be your own patient advocate and seek that information.
So if last episode was to convince you to not suffer in silence and live with these symptoms, today's episode is to answer your questions. Is HRT safe? What does HRT mean? And what are my options? So with that, why don't we dive right into this week's episode?
Balls Deep.
All right, Brooke. So let's start off kind of big picture. We hear that term HRT, or hormone replacement therapy, used very frequently. And as we talked about in the last episode, I mean, our body has, hundreds of hormones. I mean, there's a lot, right? And of course, when we're talking menopause, we're primarily talking about the sex hormones and the hormones that are affected during that time. So is it safe to say we're talking estrogen or the estradiol, progesterone or progestins, and then testosterone?
Yes, correct.
So walk us through, when a woman comes in and you're going to talk about hormone replacement therapy, how do you sort of approach that woman? Where do you start? I mean, we're talking about 3 very different hormones. And again, a woman's coming in thinking that she's going to get her thyroid fixed as well. And, oh, my cortisol levels are high. And, all of a sudden you start going down these rabbit holes. How do you sort of redirect, and what's sort of your general sort of introduction to this idea of we're going to replace hormones in your body due to menopause?
Yeah. Number one, I want to know what sent them in. What brings you into my office to have this conversation? Was it just that you're curious about what menopause is or what options are available? Are you having very specific symptoms? What do they look like? Did you read something? Did somebody tell you need to come in? I want to know what their motivating factor is to bring them into my office. And what do they hope to accomplish? I ask that a lot in my office. What do you hope to accomplish from your visit today? Because I want you to be happy when you leave. And if it's just information gaining, that's a perfectly acceptable reason to go for a hormone or menopause consult. You don't have to make a decision at that exact day. This is the great thing about menopausal treatments. You can gain information. You can get second opinions. You can do your own research. Although I say cautiously to be careful about searching the internet because you will see some very interesting and terrifying information. But second opinions from licensed healthcare providers, ideally people that are menopause certified or have that kind of expert background in menopause management or hormone management. And there's a lot of different specialties that you'll find that in. So I digress, but going back to the question about how do I have a conversation about hormone replacement therapy? Again, finding out what the array of symptoms are, what they hope to accomplish, and what treatment options, in my expert opinion, would best treat that particular patient. So for instance, if I have a patient that comes to me and they really only have vaginal symptoms or bladder symptoms, really no other array of hot flashes, night sweats, sleep disorders, then I'm going to more than likely treat locally. I'm going to treat with a vaginal product or suggest that type of treatment. If a patient comes to me and has the whole, array of hot flashes, night sweats, they're not sleeping well, their libido's low, they have vaginal dryness, their joints are hurting, just on and on and on. In that case, we start talking about more systemic options. And generally speaking, if a woman is a proper candidate and has no substantial risk factors, and also timing is a big one, within 10 years of that menopausal window, so 10 years from last menstrual period or 10 years from having the ovaries removed or chemical menopause, depending upon what that looks like for that individual patient, then generally speaking, we're not as concerned about cardiovascular concerns, which include blood clots, heart disease, stroke, that sort of thing. Now, if a woman comes to me and they're 15 years, 20 years past the point of menopause and they've never used hormones, we're going to have a different kind of array of options for that particular patient that generally are non-hormonal. But hormones are not the devil. Hormones are something that and I keep using this umbrella term, hormones. Hormones are something that we produce naturally in our body at different times in our life for different purposes. So they really are not evil, the devil, unsafe, and they're not all created equal. There's lots of different types of hormones, routes of administration, potencies, uses. The list goes on and on. And so once I understand what your history is, your age, time since menopause, full symptom profile, your goals, and also, is cost a major concern? Do you have insurance? Do you have good commercial insurance that maybe covers more name brand type medications that you get from a local pharmacy? What about, do you have any allergy to adhesives like Band-Aids? Maybe a patch is not the best thing for you if that's the case. So you really have to think through all these little pieces to come up with the best protocol for each individual patient. There is not a one-size-fits-all protocol, and I think that's where a lot of healthcare providers get into a rut when they try to treat every woman the same with anything, but especially with menopause.
This sounds really complex. I'm learning a lot just listening to you, and so that's why it always gets me angry when I hear, one news article come out or one person make this blanket statement. Mm-hmm. And it's like, well, what hormone are you even talking about, right?
Right.
And so it is complex. It is individualized. And I love how you start with the patients, their why. Why are you here today? What are you truly trying to accomplish? The fact that you're getting to the heart of what's bringing them in, so you can best customize the treatment plan, which it sounds like you do, that it's not just this blanket way of treating it. Mm-hmm. There's a lot of different variables that you've got to consider. And this is, the art of medicine, right? You can't just get in a textbook. You're simultaneously processing the woman's symptoms and her inherent risk factors and her age and preferences, and then all the ugly part of medicine like insurance and the money side of things, right? Yes. To come together with this really personalized treatment decision. So when we're talking HRT, it's so much more complex than that, isn't it?
Oh, so here we were saying last time that it's not rocket science. It's not super difficult. It's more complicated. So you have to spend time. And I think that's another big aspect. US-based healthcare, we're so focused on in and out, like getting patients in and out. You've got 3 minutes to tell your life story and all your risk factors. And it's not a safe or appropriate way to practice medicine, unfortunately. So I think that's one thing we do really well at our office is we give patients that time that they need. And I'm not saying you need an hour or 2 hours to go over everything. You can be really efficient and streamline that conversation, but it definitely takes more than 3 to 5 minutes, right? I think you would agree even with men and talking about testosterone replacement. Patients need to be invested in what you're offering to them. And I'm not even saying that from a financial standpoint. I'm saying that if I prescribe something, anything for you, and you don't understand what it is, what it does, risk factors, and then you pull out that package insert, you're going to come... You're not going to take it probably because it's going to scare the hell out of you, or you're going to call me back and say, why are you trying to kill me, right?
Right.
You told me that this was something that was going to help me, and I'm reading that it's going to kill me or it's going to cause all these awful symptoms. One thing about those package inserts, random side note, the FDA has to put, they have so many different regulations and things, and there's so much stuff that they have to put in there that may or may not be directly related to the product that you're using. So take that, I don't want to say with a grain of salt, but take that in context with the conversation that you have with your healthcare provider.
Well, I love that you brought up the time spent with patients. That's always been my non-negotiable when I started the practice over 4 years ago. Was I wasn't going to do that volume-based game, that urologist we've all met who kind of puffs out their chest. Yeah, I saw 50, 60 people in clinic today. I said, you may have seen them. You didn't give them healthcare.
Mm-hmm. Exactly.
I'm sorry. Like, it's simple math. There is no way. And I think I'm pretty efficient. I'm sure you feel the same way after almost 2 decades of doing this. That
don't tell them my age.
I won't. She's a genius. She started when she was like 12.
Yeah.
But yeah, you have to spend time with people. But again, it doesn't need to be hours and hours. It's just, again, this is the art and the experience, right?
Yeah.
You brought up the package insert. So it brought me to one of my favorite topics of vaginal estrogen cream. I think one of the hands on the most misunderstood of all the different medications we prescribe here. Yeah. The analogy I've used is telling a woman she can't use vaginal estrogen cream because it's dangerous is like telling an alcoholic he can't use an alcohol swab or he'll get drunk.
Yeah.
So walk us through vaginal estrogen cream and that scenario of the woman who comes in really more with maybe the localized symptoms, or maybe you do that risk assessment and you go, I'm not really sure systemic therapy is right for that woman. Help all of our listeners understand. Vaginal estrogen cream is 100% safe. Am I wrong?
Yeah, for sure. Aside from maybe women that are allergic to it, that's really, and you use the analogy of the alcohol swab. I love that. I use the analogy of steroid injection versus a hydrocortisone cream, still a steroid. If you get a bug bite, you're going to put a cream on that little bug bite to make it stop itching. If you have a full-fledged sinus infection that's not resolving, you need an injection of like a high potency steroid. You would never expect that hydrocortisone cream to benefit a sinus infection, right? And so that's kind of my analogy when it comes to vaginal estrogen. The potency of vaginal estrogen or hormone-based products that are used for what we call genitourinary syndrome of menopause, or GSM, formerly known as vulvovaginal atrophy or atrophic vaginitis. Basically, it's menopausal changes to the bladder, the urethra, the vagina, the vulva. When that happens, if we need to treat directly, we're going to recommend a cream, an insert, a suppository, a ring, something that's more localized that doesn't impact what we call systemic or circulating hormone levels. So for instance, if all you're using is a vaginal estrogen cream, and I check blood levels before and after, I should not see any significant change or any change whatsoever to your circulating blood levels. And so that has been looked at in multiple studies that have been published for decades now. And we're understanding more and more and appreciating that more. Yet the package insert is the exact same as if I were to give you an estrogen patch, which is significantly higher in potency, intended to raise those circulating levels. And that's another conversation, because even patches aren't relevant to that, a lot of what's in that package insert, but it's a whole different product. Even though it's the same compound, the potency is radically, radically different. And there's literally zero relevance to cardiovascular concerns such as blood clots, heart disease, stroke, breast cancer, things of that caliber. It's also not going to help your osteoporosis or your hot flashes or your night sweats. So there's good and bad associated with that. But really, that whole package insert, there's a big, big push in the international menopausal community to have that label taken off, because a lot of what we do here in the U.S. transfers into what's done in other countries. And so there's a lot of interest. There's a lot of other countries watching how we handle this. And so far, the FDA is holding steadfast that they will not remove that box warning.
Just maddening, isn't it? Yeah.
Yes.
So, I mean, here we have an advocate for women's health and, again, decades of experience and other people before you. Mm-hmm. And yet we're still fighting these ridiculous regulations and the bureaucracy of healthcare that really ends up hurting women, right?
Yes.
I mean, because if I'm a woman and my doctor's embarrassed talking about menopause, or worse, doesn't even talk to me about my menopause, and I read the package insert that maybe some doc who just, here, take this prescription, just put it on, and goes, oh God, I'm not taking this, right?
Yeah.
And so,
for good reason. I mean, it's scary, right?
Absolutely.
Yeah.
And that's why I love you're such a vocal voice, and why you're here today is to help break down some of these myths. And so, if I heard you correctly, so the vaginal estrogen cream is a form of HRT that is mainly meant to treat the symptoms of GSM, or the genitourinary symptoms of menopause.
That's one of those acronyms that you say you don't understand my language. So
yes,
keep that in the back of your mind now.
I read Brooke's charts. I'm like, I need a translator. But so for better or for worse, right? It's not going to get in your bloodstream, which has, again, it's just pros and cons, right? Not everything is good or bad.
Right.
So let's now then pivot and talk about what we'll call systemic HRT. So now we're talking about a woman getting estrogen and raising her estrogen levels. This is hugely controversial. And we previously on an episode referenced the WHI study, which was completely misinterpreted 20 plus years ago, and really, in my opinion, did a lot of damage to women and women's health.
Continues to do damage, yes.
And we talked about in that episode about the difference between an absolute risk and a relative risk. So walk us through from your perspective, I think the two big risks. So breast cancer, and then we'll kind of lump together clots, whether that clot leads to a heart attack, a stroke, or a clot in the leg, and a clot that goes to the lung, or a pulmonary embolus. So let's start with the breast cancer. So a woman comes in and goes, Brooke, I've got all these symptoms, but I am not taking estrogen because it is dangerous. It's going to cause breast cancer. And let's say for this scenario, you do an assessment and you feel this woman's at a low enough risk, say, for breast cancer. No family history. She's within that 10 years of menopause. Beyond a shadow of a doubt she'd benefit. So how do you talk her down from the ledge and undo all those myths that were done by some Reddit thread she went through?
Well, I always like to start with, I call the Women's Health Initiative the gynecologic 9/11. I was living in Philadelphia at the time, finishing, a couple areas before I moved here to Nashville. And I had encouraged my own mother to get on hormone replacement therapy. And the moment that information was disseminated across the country, and as healthcare providers, we were at the mercy of hearing what you were hearing at the same time, because a lot of the information hadn't been published yet. So we didn't really have our journals to turn to for understanding the little nuances and the reality of the Women's Health Initiative. But my own mother called me up within hours of the news just blowing up over hormones are the devil and they cause all these complications. And my mother said, I knew you were trying to kill me. I just knew it. And so I had to deal with this on a personal front as well as a professional. But after that moment, we saw hormone usage just completely tank, and it has never rebounded, even with the significant knowledge and growth and understanding of hormone usage and safety and all of that. Now, taking into context how I manage patients now and have that conversation about systemic hormones, as I've said before, you don't have to deal with these symptoms. There's options available. And when we're talking about or coming up with an approach to treating your specific symptoms, another thing to take away from the Women's Health Initiative is the scary stuff, the blood clots, the heart disease, the breast cancer. All of that is in reference to one specific type of estrogen with or without a specific type of progestin. And it was relayed that all hormones act this way, and that's not the case too. So Generally speaking, we try to avoid oral hormone usage because we know, well, let me rephrase that, oral estrogen usage, because we know that when we ingest estrogen, in most cases, there's one exception, but in most cases, when we ingest estrogen, it has to be detoxified through the liver. There's a lot of changes that happen in response to that, unrelated to the breast cancer and clots and everything. But one thing to keep in mind is it causes a rise in a protein called sex hormone binding globulin. And when that happens, that protein latches onto testosterone and renders it useless. So now you're dealing with menopausal concerns and lower testosterone. And that's another conversation I'm sure we'll have real quick here. But also, so generally speaking, we try to do a transdermal. And transdermal means it goes through the skin. So like a patch, a cream, a gel. I love the patch. It's continuous absorption. There's lots of different potencies. I generally start with a lower potency and work our way up because you don't need more than what's necessary, of course. And then we just go based on symptoms at that point. You don't have to check blood work to see where your numbers are. We have these options and these potencies. And if you're doing better, great. If you're not, we go up or we modify the route of administration or the type of hormone.
But to that woman who, again, is going to say, hey, but I'm worried about breast. That's great, Brooke, but what about breast cancer? I read that this is going to increase the risk.
I totally dodged that, didn't I?
Yeah.
I was like, I'm going to give you a ton of information that I want to tell you. So, yes, I'm glad you came back to the original question about breast cancer. There is basically no evidence to show that plant-derived estradiol, and I'm not saying you have to go to a compounding pharmacy. There's tons of commercially available plant-derived bioidentical forms of estrogen called estradiol, that is connected with inducing breast cancer or breast tumors. Now, if you have a tumor or you develop a breast cancer from whatever, background or reason, and it grows in response to hormones, yes, we reevaluate and make a decision. Is this the right option for you? Because it could potentially feed it or make it grow more rapidly. But generally speaking, the types of hormones that we prescribe do not generally cause breast cancer to develop. And that's a big difference from what was relayed to us as healthcare professionals and as the general population.
And it could even be the progestin component, correct? Again, in that WHI study, that it was that group really that was of more concern.
Yeah.
And what about the risk of clots? So how do you walk a woman through that? Oh, my dad or mom had heart disease and I'm worried about that. How do you kind of walk them through that risk?
One thing we talked about last podcast was how estrogen is very lubricating. And when we think about that impact on blood vessels, so blood vessels are stretchy, elastic, they give, they move with our body. There's blood pumping, and so they're constantly contracting. When estrogen depletes over time, blood vessels become a little bit hardened and less elastic, and hormone-rich blood is a little bit thicker. So when blood is pumping through these blood vessels and you throw in some extra hormones and it's a slight bit thicker, and then you've got these inelastic blood vessels, that's where there's an uptick in clots and heart disease and stroke and so forth. That generally occurs 10 plus years past the point of menopause. So that's where timing comes into the mix, which I've mentioned earlier. If a patient comes to me and they're 10 years since their last period or since having their ovaries removed or starting a medication that suppresses their ovarian function and their risk factor profile is appropriate, that's a great time to initiate hormone replacement, not just to eliminate symptoms, but to maintain, a lot of that cardiovascular benefit and bone health and so forth. If a patient comes to me and they're 15, 20 years past that point of menopause, they're generally not a candidate in most cases for inducing or starting hormone replacement therapy at that point.
And I think if we go back to the Women's Health Initiative to kind of bury the hatchet there, those women, if I remember, were a bit older, right? They were further along in menopause, which again is not what you're talking about.
Yep,
and
already high risk.
They're already high risk, right? And then I think another thing is, you talked before about an individualized approach, right? If a woman is at a higher risk for osteoporosis because she's thin, maybe she doesn't do a lot of weight-bearing exercise, and she's got no diabetes, she doesn't smoke, whatever it is, is it fair to say you might do a risk assessment, go, yeah, I know it's been more than 10 years, but honestly, I'm more worried about keeping your bones strong, and estrogen's really good at that, right? And so it's also this individualized approach that you go to. Again, it's not this rigid idea of yes or no. It's a risk assessment.
Yeah, absolutely. And that's where it comes down to, an individualized approach. And that's another thing that we do really well at the office, is we're all very focused on giving individualized attention and coming up with an individualized plan. We're not a cattle mill operation in any context. Everybody's going to have their own little variation on what's unique for their healthcare plan. And I guess I'll leave it at that.
Love it. Love it. Well, I don't know whether to open this rabbit hole because I think we're reaching the end of our podcast, but maybe we'll just tease at it, go a little quick.
I know what you're about to ask.
On your soapbox, and then maybe there's going to be a whole other episode, honestly. I
think it needs to be.
But let's just give people a little taste here. So why is there no FDA-approved testosterone for women? Mm-hmm. Why is it that testosterone, which is really a dominant hormone in women, has been studied for longer than you and I have been around? Mm-hmm. Why is there still no way for the FDA to say, yeah, you can give a woman testosterone?
Yeah, there's a way. They can say yes. We have enormous published studies, data, information, experts that are familiar with properly using testosterone in women. There was a product that went up before the FDA, 15 years ago, I'm trying to remember exactly when, called Intrinsa. It was a patch. It was designed for women to deliver testosterone because, as you alluded to, women produce more testosterone than even their female hormones, estrogen and progesterone. So it's a real component of hormone replacement therapy. The FDA looked at this data and said, this looks great, safe, effective. We don't have one yet. So let's get 5 more years of data before we approach this again. And so, as you can imagine, research, especially 5 years of research in that context, is extremely expensive. So it was going to equate to about $1 billion worth of research.
Wow.
When they'd already invested probably about $1 billion at that point. And so, unfortunately, investors, companies, we went from all this excitement over finally having a testosterone for women to crickets. And we're starting to see an uptick in interest in some studies, and hopefully at some point we'll see this approval, but it's just absolutely maddening that this organization that is supposed to be verifying safety and efficacy of products is, in my opinion, very inappropriately, there's a lot of bias. Let me put it that way. How long did Viagra go through the process of approval before we actually saw it on the market? You want to know? Do you know that?
I don't know the answer, but I bet
6 months.
I bet it's pretty quick. Because those guys in the FDA were like, oh, we need this.
Right. So heaven forbid you can't get an erection, and I'm not taking away from erectile dysfunction. It's very, very important. But, I mean, it's just silly. I mean, if you think about some of the risk factors of some of the medications used for erectile dysfunction, and then you look at the risk profile for testosterone in women, it's almost laughable. So
the FDA sounds like your insurance company for me, and we've got some bottles of bourbon over here. I think we continue this conversation to talk about. But
yes, it's very important. I use it off-label in many cases. We have a published protocol through the International Society for the Study of Women's Sexual Health on how and when to use testosterone. So we can still use it. I want to leave you at that. But yeah, there's an ongoing fight in many areas of women's healthcare, especially when it comes to menopause and sexual health.
Well, Brooke, thank you for being a champion for women everywhere. I mean, it's just, I'm so excited about the future of not only our practice, but I think just nationally, there's a lot of colleagues of ours who are getting up on soapboxes on social media and building practices for women.
Yeah.
And there has been this inherent bias towards healthcare for men, and it's got to change. I mean, women are the stalwarts of the home. They are the real advocates for health. I mean, if it's up to a guy, we're just going to sit around and drink beer and never get off a couch. I mean, so, as someone said, we're treating ED in men. We're giving guys Ferraris, and we give them no place to put it.
Yes.
Right?
Yes.
So our beloved colleague, Dr. Tapscott, came up with that analogy.
I love it. It's great.
And it's so true, right? There's it's a couple. It's a team approach. You can't treat the man without treating the woman as well. And so thank you for everything you do. And I think it sounds like we have to have you back because we at least got to go into testosterone. I have so many other questions, female sexual health. So
if you might want to bring a helmet and some elbow pads because it's going to get dirty when we start talking about testosterone. I get a little bit heated, so you just have to protect yourself from the flailing hands and stuff. I'll
get on my University of Michigan gear. I didn't go to Michigan, but I know the touch point there I was hitting. So I did notice you're wearing the Buckeye red.
I sure am, yeah.
So with that, why don't we conclude today's episode with our favorite segment?
Just the tip.
Okay, so what did we learn today? So when it comes to treatment, first off, vaginal hormone replacement therapy, or HRT, is safe and very different than systemic HRT. Number 2, it is best to start HRT within 10 years of menopause, although it's really important to take an individualized approach. And lastly, testosterone replacement in women is appropriate. There are guidelines, it's safe, and just because the FDA is in the ice ages doesn't mean that you can't see a licensed professional with expertise in this and be put on testosterone if it's appropriate.
Yes, 100%.
Okay, love it. Well, Brooke, this is awesome. A lot of fun. I'm concerned about the costume changes I'm now going to go through with every podcast episode, but otherwise we'd love to have you back. So.
Yeah, next time I'd like to see a different shirt, please.
Okay, fair enough. So, Stream team, thanks again. This is awesome. We really appreciate the support, and we really want to hear from you. So please leave some comments for me, for Brooke. We'd love to do an episode where we address your concerns about HRT or anything urology or wellness. So we do look at those, and please remember to always show yourself love and grace. We're all works in progress, and these are opportunities to grow. Thanks, and have an awesome day.
Thank you for listening to this week's episode of Balls Deep. If you'd like to join our Stream team of listeners, please click the subscribe button on your favorite podcast platform. For more information about our practice, Pazona MD, please visit pazonamd.com. This podcast is for informational purposes only, and the content is not intended to be a substitute for professional medical advice. The show does not constitute the practice of medicine. No doctor-patient relationship is formed through this podcast or any of the social media channels related to this show. The use of this information is at the user's own risk. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.